Good morning again. Uh, Dr. Nilesh Ghelani sir is having health issues, so he is not here, unfortunately. So I am just presenting his paper. Uh, present. So challenges in reconstruction of the limb sarcoma defect. Mostly it is on the algorithm we can follow. So soft tissue and bone sarcomas, it includes the 1% of the adult malignancies and 15% of the pediatric malignancies. 3/4 of the sarcoma occur in the extremity, and of which out of which 3/4 occurs in the lower limbs. So it's challenging for the plastic surgeons to reconstruct the lower limb defects because of its inherent problems. So now the concept has changed, and early concept was the amputation of the limb for the survival of the patient, but recent concept is there. So limb preservation surgery should be there because of availability of the good prosthesis, era of the microsurgery, and evaluation of the tissue transfer surgeries and the good adjuvant radio and chemotherapy. So survival is there, and good infrastructure, skills, and microsurgery facilities are there. So these are the implants used by the ortho-oncosurgeons for the limb preservation after the defect, bony defects, uh, microvascular tissue transfers at the ease nowadays. So improvement in the adjuvant and chemoradiotherapy is also the factor for the limb preservation surgery, advantages factor. So through the limb preservation surgery carries the higher risk of the local recurrence, but overall survival rate is the same. But the limb preservation should not delay the adjuvant and radio and chemotherapy that patient should receive within the 3 months following the surgery. So classification of the sarcomas according to the regions around the shoulder, arm, elbow, forearm, hand, trunk lesions, thighs, knee joint, legs, and foot and ankle. So shoulder region, there is a large lesion over the shoulder. Available options are LD myocutaneous flaps and pectoralis major myocutaneous flap. We usually prefer microvascular transfer, but in such cases, scenarios where infrastructure is not available, patient affordability and other factors are there, so we can also use the locoregional and distant flaps. So LD for the latissimus dorsi muscle. So after implant excision of the tumor and implant placement and mesh placement, LD nicely covered the defect. Primary closure of the donor site is there. So another case performed by the LD muscle flap. Pectoralis major is also used for the shoulder defect. It is easily robust and reliable flap and easily approach to the shoulder. So upper arm defects are also covered with the PM and LD muscles. LD can reach up to the just distant arm region. This is another case of PMMC. So lesions around arm, LD, radial forearm flap, and ALT free flap are the options. So LD muscle can reach up to the distant arm, just below the just before proximal to elbow we can reach, and donor side can be primarily closed. Lesions around arm, another lesion. So it is covered with the radial forearm flap. Another lesion covered with the radial forearm flap. Lesion around elbow, abdominal flap, radial forearm flap, and ALT flaps are the options. So this defect is covered with the free ALT flap, nicely contoured. Another radial forearm flap for the elbow, abdominal flap for the elbow, forearm lesion with the radial forearm. Prefibula is the another option when bone is involved. So nicely plating done by the ortho-onco surgeons, and fibula is nicely settled. Another defect covered with the ALT flap. Another recurrent case, in where recurrent cases are there, radiation is there, then sometimes we have to go for the distant flaps, groin flap, reliable flaps. It is also very much useful, and in armamentarium for the sarcoma resection. Small defects for abdominal flap is covering it. Cross finger flap. Lesion on the trunk, skin graft, perforator flaps and keystone flaps are the options, as yesterday sir has discussed. We can do HCG in some cases where radiation is not needed. Lesions over back, large rotator and perforator based flaps, LD flaps, we can use keystone perforator flap. Lesions over thigh, skin graft, free LT flap and free fibula flap can be used. This is a large defect, so ALT harvested from the another thigh and covered the defect. Another large sarcoma, defect was covered with the ALT. Another implant was placed in the thigh after excision of the femur was involved. So large ALT flap was done to cover the implant. Another defect covered with the ALT flap. So large flap can be harvested. Another lesion. So this is young girl having recurrent cases and post radiotherapy with deformity of the leg. So ortho oncosurgeon placed the distractor implant, and it was covered with the free ALT flap, and it was distracted gradually for the limb shortening, and it was having a good results. This is the how they distract the implant gradually, and long post-op follow-up. Lesions over thigh, there is another implant and covered. Local flaps are also useful. So when vessels are also involved in the sarcoma, then we can use the vein grafts to loop around it and preserve the limb. Gastrocnemius, local flaps are robust flaps, easy to harvest and reliable flaps. Gastrocnemius for knee defects, popliteal defects. Another flaps, we can also cover the implant. Local flaps are also helpful for covering such defects. So lesions over the leg, anterior aspect of the leg, which can be covered with the local muscle flaps and free flaps like ALT. Another case by covered with the ALT. Mostly in these cases, post radiation radiation history is there, so we do not use the superficial venous system. We always find the deeper vessels and used to anastomose with the popliteal branch or any tibial branches or tibial veins. And in also thigh, we use the lateral circumflex femoral vessels for the anastomosis. So for the foot and ankle region lesions, ALT flap are good options. Radial flap for the superficial defects. Another radial flap. Fibula flaps for the bony defects. This is the post-op X-ray. So we have experienced more than 250 cases of the sarcoma defect reconstruction by the single ortho-oncosurgeon and single plastic surgeon. 85% of the limb salvage rate of the hospital, that is well comparable to the bigger institute. No difference in the recurrence rate in primary amputation cases and the limb salvage cases. Majority of our work is head and neck cancer defect and reconstruction, infective and traumatic limb defect. reconstruction and sarcoma defect reconstruction. Sarcoma defect is more challenging, unlike the monotonous defect of the head and neck cancer, where vessel size and flow is predictable, but not it is always there in the sarcoma cases. And majority times you have to do end-to-side anastomosis with the major vessels. Many a times areas have been irradiated, making it difficult to find the pliable vessels, and sometimes have to do anastomosis in an awkward position due to placement of the prosthesis, and still overall survival of the free tissue transfer is more than 90%. Thank you.